So welcome everyone to today's Hematology Deep Dive. I'm very privileged to be offered to chair this meeting as we have the very astute and erudite Professor John Eichelboom, who, as you might have known, is a Canadian working at the mecca of thrombosis, under whose mentor was Jack Hirsch, and has spent some time in South Africa, even though he is an Australian, and we'll forgive him for that. So he is going to be talking today on anticoagulation in 2025, lessons learned from recent clinical studies. And there we go. So just some housekeeping rules. These are the people, as you all are aware, from the deep dive. We won't go through them. And now to next slide. All our sessions are recorded and been found on the website. And add questions or comments to the chat box during the meeting, and we will talk to them at the end. And I know that John is going to be asking questions to the audience, and we're going to take polls and see how much or how little you know. CPD points, we have to be in here for an hour. So make sure your CPD or HPCSA number is entered correctly when you signed in. And lastly, you can join the mailing list. And please, if you need feedback, you can give an anonymous feedback at the end of the Zoom meeting. This is an advert for the annual Hematology Oncology Conference, which is happening in Cape Town from the 19th to the 21st of September, imminently coming up. And for those of you that are in Cape Town or want to travel, we urge you to join this meeting. So, moving on. So today we're going to be having lessons from the recent clinical trial from John, be a question and answer session, and then closing. And as we said, John Eichelboom hails from McMaster's, which is the Mecca, and his research is basically in the efficacy and safety of antithrombotic therapies for arterial, venous, and cardiac thrombosis, and has had a lot of support from the industry and has 800 peer-reviewed articles. So next week we'll be talking on from diagnosis to deep response, optimizing first-line therapy in CML from Dr. Maraj. And without further ado, I'm going to hand over to John.
Wonderful. Thank you very much for your introduction, Barry. Thank you, Estelle, Gerdin, and Nicole for all the logistics and putting up with me, which I greatly appreciate. And I think I am now sharing my slides.
Yes, you are.
Good. And I just need to make them full screen.
There we go.
We're good?
No, not yet.
You can't see my slide yet.
Oh, we can see your slides, but you need to start the slideshow.
Okay. So you're seeing the, what are you seeing?
We're seeing the outlay of 12 slides.
Oh, okay.
We need to start the slideshow.
I've forgotten to start slideshow. End slideshow. It looks like I've started slideshow.
Well, no, it doesn't.
Nicole, what am I doing wrong?
If you go to in the top toolbar, it'll say slideshow, and then there'll be an option to say.
You need to go type. You need to go where the arrow is on the top. It's the fifth next. You're on home at the moment, so you need to go across to slideshow.
Okay.
No.
Yeah.
I can't see your arrow.
Am I sharing now? No.
No.
Okay, do it at your end for me, please.
Yeah, sure, no problem. Just give me a sec.
Just do it there because I never have this trouble. Something's on. But
no problem.
But in the meantime,
It's a cross between the Canadian and the Australian problem. Should come to South Africa.
So I'll start, assuming that Amanda's smiling at us. So the background is I've spent 30 years doing research in thrombosis and hemostasis, and the one area that I find the most exciting is to look at the direct interface between what clinical trials are showing us and what we do at the bedside. And so the purpose of my presentation today is to tackle several issues that come directly from the clinical trials that are directly applicable to the bedside. These are my disclosures. Next slide. Oh, I can control it
You can click
myself.
through, yeah.
So 3 years ago, when I gave a presentation in this same forum, I showed this same slide. And at that time, I took you through the story of the discovery by serendipity of heparins, the emergence of low molecular weight heparins, and then the big change, the direct oral anticoagulants. And I touched on a new class of drug, the factor 11 inhibitors. What I'm going to do today is to reflect on the direct oral anticoagulants in particular and how they've changed practice, but more importantly, where there are still gaps and uncertainties. And then I will end by discussing where we're at with the factor 11 inhibitors. Now, direct oral anticoagulants have been very widely tested in venous thrombosis, in arterial thrombosis, and in cardiac thrombosis. One of the areas where I think we've learned the most about direct oral anticoagulants is in atrial fibrillation. And why is that? Well, firstly, very large trials. Secondly, a spectrum of relatively healthy individuals to very frail individuals. And thirdly, these trials have been conducted over all continents, over almost all continents, with very heterogeneous populations, which allows us to explore in subgroups. So a lot of what I'm going to say is applicable particularly to atrial fibrillation, but has lessons more broadly. Now, the data from randomized trials in atrial fibrillation have been recently summarized in a single individual patient database meta-analysis. And you will see slides coming up during my presentation from this combined AF meta-analysis. This is 5 trials, 71,000 patients, 4 trials that compared warfarin with the DOAC, and 1 trial that compared aspirin with the DOAC. So that's the background. A lot of what I say will refer to these data, and in particular to the pooled data, which show that on average, a direct oral anticoagulant versus warfarin in patients with atrial fibrillation reduces stroke, reduces mortality, reduces major bleeding, and reduces intracranial bleeding. Well, I want to warm you up with a practice question. And the question is, there's no right or wrong answer. I just want to hear what you've got to say regarding direct oral anticoagulants. And the question will pop up in a moment and you can start to vote. 1, they should be preferred over vitamin K antagonists for most VTE AF patients. 2, the head-to-head data are limited, therefore patient factors dominate the choice between them. And 3, bleeding risk can be managed and should not be a barrier. And someone says there's no slideshow, Nicole, but
so the practice question I missed is one of the questions, so it'll have to be a practice verbal answers as well.
Okay, well, this is was to make you vote and to just hear what you had to say. But we'll come back to some of these items in a moment. So I'm going to carry on. So what am I going to talk about during this presentation? I'm going to talk about where DOACs underperform. Secondly, I'm going to talk about bleeding, its scope, and possible approaches to prevention. And the third area of my presentation, I'm going to discuss factor 11 inhibition and the future. So let me start where DOACs underperform. I've summarized in this table the DOAC failures, and there are three categories where DOACs underperform. One is where they're proven to be inferior to warfarin, rheumatic atrial fibrillation, mechanical heart valves, and triple positive antiphospholipid antibody syndrome. There is an area, or there are areas where the DOACs are of uncertain efficacy. This includes obesity. This includes breakthrough stroke in patients with atrial fibrillation. It includes the frail elderly and advanced kidney disease. And then the third area where DOACs fail is where they're contraindicated. For example, drug-drug interactions with strong PGP CYP3A4 inducers and advanced liver disease. Now, I just saw a great question about triple positive antiphospholipid antibody syndrome. I wasn't going to speak about this in detail, but this would merit a presentation by itself. And I can't tackle all of these in detail, but I would like to come back to that in the discussion. And Nicole, maybe you can keep a register of questions. That's an important one that I'd like to come back to. I'm going to start by talking about two areas, rheumatic atrial fibrillation and obesity. Now, I have spoken about rheumatic atrial fibrillation at the last meeting when I presented, but I want to bring up this again and link it with obesity because it's going to show us some unique insights into possible underlying mechanisms. Now, here's case one. We have a 42-year-old woman. She has rheumatic mitral stenosis and she has atrial fibrillation. Her mitral stenosis is moderate to severe. She's on warfarin and she's poorly controlled with a time and therapeutic range of under 40%. And you're in your clinic and she comes in and the question you face is, should I switch to rivaroxaban? Now, I'd like to know what people on this at this meeting would do. So regarding rheumatic atrial fibrillation, true or false, vitamin K antagonists should be preferred over DOACs in most people. So each one of these, you've got to mark true or false. Vitamin K antagonists are associated with lower risk of stroke than DOACs. Vitamin K antagonists and DOACs have the same rate of mortality. And DOACs are a reasonable option when VKAs cannot be effectively monitored or control is poor. And I don't know whether if it's 6 out of 6, that means people are saying yes, yes, or yes, no. So Nicole, you're going to reveal this to me.
I'm not sure how you if you click on it, if it's a yes or a no. So it's
No,
only
so
got true.
So I made it a select all that are true. So it's a true false by.
But on my screen it doesn't.
So for question one, for each of those statements, if you click on it, you're saying it's true, if that makes sense.
Okay. Well, I hope that works out. And Nicole, I'm going to let you decide how long to go. We've got 19 responses, and I see there's 120 odd people on the call. So a lot of people are not voting yet. So please get those.
And it is anonymous, so no one is judging you if you get the answer wrong. We can't see who you are.
And some people are already voting on question 2, but I'd like you just to vote on question 1. And so far, it would seem to me that most people think vitamin K antagonists should be preferred, that less than 50% think that vitamin K antagonists reduce the risk of stroke compared with DOACs in this population. Very few people think that they've got the same rate of mortality. And most people think that DOACs are a reasonable option when vitamin K antagonists cannot be effectively monitored or controlled as poor. And that's a really important set of responses that I want to come back to once you close the questioning, Nicole, which I guess would be about any time now.
Yeah, I think that's probably good now.
Good. So, well, let's take a little look at the Invictus trial results on the next slide. I go back. What do I do here?
Click on there.
Do I close this?
No, you're fine. It's closed. We can see. You can carry on.
Oh, okay. Oh, there we are. Let me back up. There we are. So the Invictus trial was a trial conducted mainly in low and middle income countries in patients with rheumatic atrial fibrillation. And most people had rheumatic atrial fibrillation, and it compared rivaroxaban with warfarin. And at the outset of this trial, the folks who did it from McMaster, in collaboration with the steering committee around the world, were firmly convinced that because in atrial fibrillation without rheumatic heart disease, rivaroxaban was better than warfarin, it would be in these people. Well, lo and behold, shock horror, after 4,500 patients were randomized with a very high level of follow-up, with decent warfarin control, warfarin proved to be superior to rivaroxaban at 4 years of follow-up, with a lower rate of stroke, systemic embolism, MI, or death. But that's not the full story, because when we look at the curves, there is a crossover of the curves after 18 months. Now, we sometimes see crossovers of curves when we have surgical trials, because early on the surgery induces some side effect, but then later on the medical arm catches up. But these were just people treated with anticoagulants. So a delayed onset of benefit of vitamin K antagonists, and then the benefit was driven primarily by a lower risk of death with vitamin K antagonists than with rivaroxaban. There was a reduction in the risk of stroke with VKA compared with rivaroxaban. These hazard ratios reflect a higher rate with rivaroxaban. So overall, vitamin K antagonist superiority driven by death, a reduction in ischemic stroke, which is relatively modest, and the difference was not explained by bleeding. I'm showing my slide. Someone's asking whether there is a slideshow. Charlene, I don't know, but I'm seeing slides.
Yes, we can see the slides.
So why was warfarin superior to rivaroxaban? The difference was only in part explained by a difference in stroke, because there were 26 ischemic stroke differences and 110 deaths. It was not explained by bleeding, and when greater scrutiny was placed on the deaths, the mortality reduction was driven entirely by heart failure and sudden cardiac death. How could this be possible? Well, we did some further exploration, and I want to show you this figure of the effect of vitamin K, or the effect of coumarins on vitamin K dependent proteins. We're all familiar with the effect of coumarins affecting carboxylation of vitamin K dependent proteins in the blood. And you see coumarin impairs vitamin K epoxide reductase, and therefore it actually prevents this gamma carboxylation. But the effects of coumarins are not restricted to the blood. There are a series of vitamin K dependent proteins found in the tissues, and one is of particular interest, and that is GAS6. So what is GAS6? Growth arrest specific gene 6. This is a protein that's been investigated in cardiovascular disease, and there are significant associations between GAS6 protein levels and the risk of venous thromboembolism, adverse effects in sepsis, but specifically in heart failure and obesity. Elevated GAS6 levels predict all-cause and cardiovascular mortality. One might anticipate that because these are tissue-based proteins, that any effect of vitamin K antagonists on GAS6 would be delayed. And so there is a plausible hypothesis that the benefits of vitamin K antagonists in rheumatic heart disease are mediated by suppression of GAS6. Here are some data from GAS6 in heart failure patients. This is from a heart failure trial. The lower the level of GAS6, the lower the rates of mortality, of all-cause mortality or cardiovascular mortality. GAS6 interacts with the TAM receptors in patients with cardiovascular disease, which are activated particularly in the setting of obesity and heart failure. And remember that the driver of death in patients with rheumatic heart disease was heart failure deaths or sudden cardiac death. It does fit a plausible hypothesis. Now, note that GAS6 is particularly relevant in patients with obesity. And I'm going to show you a slide from the combined AF analysis, looking at the effects of treatment with a vitamin K antagonist versus a DOAC according to baseline BMI. On the left upper panel, you see the effect on stroke or systemic embolism. Throughout the range of BMI, DOACs appear to be superior to warfarin for preventing stroke. The second panel, the same for ischemic stroke. The third panel, more or less the same for bleeding. The lines converge at the upper end of BMI. For intracranial hemorrhage, there is a clear benefit across the spectrum of body weight. But when we look at net clinical benefit, the lines cross at a BMI of 35, and this crossing of the line is driven by all-cause mortality. And guess what the cause of death is in people with a high BMI? It's heart failure and sudden cardiac death. So these first two cases, rheumatic atrial fibrillation, or these first two scenarios, rheumatic atrial fibrillation and this observation in obesity, raise the hypothesis that vitamin K antagonists have a clear benefit over DOACs in settings where vitamin K dependent tissue-based proteins may otherwise cause harm. So I'm going to conclude from case 1, rheumatic mitral stenosis, that the Invictus results confirm that for rheumatic mitral stenosis, we should stick with vitamin K antagonists. Second, that the GAS6 TAM hypothesis requires prospective testing. But thirdly, I agree with the majority of folks who said it may yet be reasonable to use a DOAC if vitamin K antagonists cannot be used. Because if you can't control warfarin, then you're almost certainly going to be better off on a DOAC rather than taking nothing. So I should have here my summary slide for my questions. I don't know where that's gone, but bottom line, I agree with you, your sentiments. Certainly vitamin K antagonists should be preferred. Vitamin K antagonists lower stroke in people with AF, rheumatic AF compared to DOACs. Vitamin K antagonists also lower mortality compared with DOACs in rheumatic heart failure, rheumatic atrial fibrillation. But if you can't use a vitamin K antagonist, then it's reasonable to use a DOAC. I'm going to move on to my second case, and another example of DOAC relative failures. But here I want to look at this issue of breakthrough stroke. And I also want to look later on at the frail elderly. So let me start by case 2. And this is a 69-year-old woman, and she has atrial fibrillation. She has a CHADS VASC score of 4, which includes hypertension, type 2 diabetes, and heart failure, and her age. She's treated with apixaban 5 milligrams twice daily, and she's admitted with a right hemiparesis. So what's the cause of this person's stroke? Is it perhaps a bleed? Is it small vessel disease? Is it large vessel disease? Or is it a cardioembolic stroke which has occurred despite anticoagulation? And there are a whole bunch of reasons why someone might have a breakthrough stroke despite anticoagulation, including perhaps hypercoagulability and antiphospholipid syndrome or cancer. This is a common scenario, one that almost on a daily basis at my hospital, I'm consulted about. From a stroke physician saying, I have a breakthrough stroke despite using a direct oral anticoagulant. What's the next step in such situations? Well, my first approach, after we've determined that this is a breakthrough cardioembolic pattern stroke and that there is no obvious hypercoagulability such as cancer, is to do a DOAC exposure check. I'm going to look for adherence. I'm going to look for perhaps a history of malabsorption, such as might occur in some GI syndrome or previous bariatric surgery. I'm going to consider drug-drug interactions. And I'm going to consider the upper extremes of body weight, where we know that drug levels may be unacceptably low. One tip for clinicians, which I reiterate every time I see a case like this, which is very often, is please, 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 when a patient comes in with a breakthrough thromboembolic event, always, if possible, measure a DOAC drug level. So the workup of this case, it's confirmed to be an ischemic stroke. There is no significant large vessel disease. There is no LV thrombus. There is no identifiable cancer. And the apixaban level 4 hours post-dose is 186 nanograms per mil. Now, what's that mean? I'm sure that not all of your hospitals have access to these levels. And that's a great question, Jacques. I don't know if it's available in South Africa, but we have it available 24/7 here. And it's incredibly
it is available in South Africa.
Great. So it is available. And why is it valuable? Because there are very good data. We've just published this paper on the usual on-treatment ranges of DOAC concentrations. And if we look here under apixaban 5 milligrams twice daily, there are about 3,500 people who contribute to these data from about 15 to 20 studies. And the usual on-therapy range of DOAC drug levels is shown for 5 milligrams. The peak median is 216, and the range is from about 132 to 343. So this patient has a drug level that is in the usual on-treatment range. Therefore, technically, she meets the criterion for a breakthrough event. Now, what are we going to do with these people? Because it's incredibly challenging to manage someone like this. I want to remind you that, in fact, it's no surprise that we will see some breakthrough events. And these are data from the combined AF data set in people with atrial fibrillation categorized according to their CHA2DS2-VASc score. And if you have a CHA2DS2-VASc score of 7, which is way up there, your risk of stroke in the next 3 years is going to be in the order of 7 to 8%, despite taking an anticoagulant. So that's one message. Breakthrough events are not uncommon. So you've got this patient in your hospital. They've had their stroke, and your stroke doctor says to you, please help to advise, what should I do in future to make sure that my high-risk people are better protected against the risk of stroke? So look at question 2 here. Click any and all with which you agree. So would you prefer, should you prefer in general, warfarin over a DOAC? Should you, in people who are at high risk of stroke, should you add aspirin to an anticoagulant? Should you monitor your apixaban drug levels? Or should you perform catheter ablation or left atrial appendage occlusion? Or is this all a bit too much? You should just treat them as usual with a DOAC. There is no indication for improving, enhancing their stroke protection. So at the moment, about half of folks say, well, if you're at high risk of stroke, you should prefer warfarin. About half of folks say, well, maybe you should add aspirin. About half of folks say, well, you should monitor apixaban levels. A quarter of folks who have responded so far said, do some mechanical procedure in high-risk people because they need extra protection. And then about 20% of folks are saying, this is all way too much over the top. The key thing is get them on anticoagulants. Even if they're at high risk of stroke, we can't change the world. We can only do what we can and just keep them on single agent antiplatelet therapy. We're up to about 35 people, so I think we can stop there. Nicole, do I click share results or can you see this?
So I've closed it from my side. I think everyone just has to click exit.
So I've got to click stop sharing. Should
Correct. Yes.
I? Okay.
No, now we can't see it anymore.
Let me share the results.
Yeah, that's perfect.
Okay.
There
So
we
these
go.
are the results at the moment. It's about half-half, preferring warfarin, adding aspirin, monitoring levels, performing catheter ablation, or none of the above. Well, I'm going to come back to this in a moment. So let me go back to my presentation because I'm going to address those questions. The first thing is, in people who are at high risk of stroke, we already know that left atrial appendage occlusion works. We can block the left atrial appendage with a device. This is a Watchman device. We can also close this appendage at the time of cardiac surgery. And today, if you have cardiac surgery at our institution and you've got atrial fibrillation, you are going to get your left atrial appendage closed for sure. The LAOS 3 study, which was done at our place, tested this and showed that independently of anticoagulation, if you close the left atrial appendage with a suture or you snip it off, you will reduce the risk of stroke in atrial fibrillation by 1/3. What's fascinating about these data is even in the presence of anticoagulation. On the left panel, vitamin K antagonist. On the middle panel, no oral anticoagulant. And on the right panel, in the presence of DOACs, closing that appendage will reduce the risk of stroke. So this is an intriguing possibility in people who are at high risk of stroke. But at this moment, we do not have any proven evidence that people who are at high risk of stroke should routinely have the appendage closed. We are testing this in a trial called LAOS 4. So LAOS 3 is the study that demonstrated that left atrial appendage occlusion is effective. LAOS 4 is testing whether closing the appendage in people with atrial fibrillation who are at high risk of stroke and who are taking an oral anticoagulant will be of benefit. And so they're being randomized to a Watchman device or no Watchman device, and everybody gets an anticoagulant. Now, there are other non-pharmacologic approaches to reducing the risk of stroke in atrial fibrillation. For example, catheter ablation might be effective. This is a meta-analysis, and I draw your attention to the pink panel on the right. Catheter ablation in these data suggested that this would reduce the risk of stroke, but many of the studies were of low quality. So most of our EP physicians would not yet routinely recommend catheter ablation to reduce the risk of stroke. So that's preventing a stroke in a high-risk patient. But there is another element to this story. Once these people have a stroke, they are incredibly high risk of further strokes. And here are the 1-year rates of stroke in people who have a breakthrough event. It's almost 10% in the first year after stroke. What do we do once they've had their stroke? To this question, no one has an answer. We've done some post hoc analyses recently from the combined AF data set. And what these data suggest is that in these patients who have had a breakthrough stroke, warfarin may be the answer. And is that rational? Is that logical? Is that plausible? Well, it's very possible that the people who experience a breakthrough stroke are those small percentage of people who have very low DOAC drug levels in their blood. I'm going to draw this case to a close. The case is instructive for several reasons. Firstly, there are certain people who are at high risk of stroke. We don't know what to do about them except give them standard anticoagulation. There is no evidence for switching them to warfarin in anticipation of their high risk. There is no evidence of adding aspirin to warfarin in these people. There is no evidence of monitoring apixaban levels in these people. There is also no evidence of routinely closing their left atrial appendage. If you happen to be at cardiac surgery, I'd certainly have it closed, but there is no evidence to do so routinely. So for my question, I would say that the last answer, simply treating them the way we normally do, is our only option for the moment. But when a stroke occurs on a DOAC, we've got a real conundrum. We need to search for competing mechanisms. We need to verify exposure. It would be reasonable to consider mechanistically a different DOAC. We don't add aspirin, and there are randomized trials of combining oral anticoagulation and ablation in people at high risk. Should we switch people who have had a stroke on a DOAC to warfarin? We don't know. And we've just put in a grant to try to study this question. So that's my case 2. We've now gone through 2 cases, one with rheumatic atrial fibrillation, which I complemented with the obesity question, a second on breakthrough stroke. The third, very briefly, I'm going to talk about the frail elderly. Now, our frail elderly person might be your classic person in the clinic with atrial fibrillation and multi-morbidity. This person is 84. He's a male. He has a CHA2DS2-VASc score of 6. He's got moderate renal impairment. He's reasonably well managed on warfarin. The question is, we've got an old person. They're at high risk of bleeding. We know from the combined AF dataset that DOACs compared with warfarin reduce the risk overall of stroke, of bleeding, of mortality. Should I switch this 84-year-old to a direct oral anticoagulant? So I'd like to know what you would do in this case. And here, one answer is sufficient, but you can choose more than one if you wish to do so. I think that's the way it's been set up. So let's go to question 3, and we'll go down the page. Can you see question 3? So in a frail elderly patient with AF who's well controlled on a vitamin K antagonist, do you keep them on the same? Do you switch to a reduced target INR of 1.5 to 2.5 because you're worried about the risk of bleeding? Do you switch to a DOAC? That doesn't seem to be very popular, although it may be gaining a little bit of popularity. Do you say, look, it's all too hard. We're going to get you off anticoagulants. Do we switch you to aspirin? Or do you have another option? And I think that most folks are saying, just keep them on warfarin. Don't switch them. This is a well-educated group. Although I don't know what the right answer is, we'll come back to it. And I think 24 out of 37, so 2/3 of folk are saying no change, just plug on with warfarin. Some people are going to reduce the INR target, and 15% are going to switch to a DOAC. Well, that's super interesting. So let's stop sharing that and let's go to our case. Well, I'm going to refer to our combined AF data set once again, and I'm going to show you a subgroup from the 70,000 people included in this data set. And you will see this subgroup is an age subgroup. So it's not a frailty subgroup, but it is informative. And on the left, you see that with increasing age right up to about 100, the benefits of DOACs compared with warfarin appear very consistent, with overall less stroke compared with warfarin. On the right-hand side, this is the bleeding with a DOAC versus warfarin. There does seem to be a crossing over of the line at about age 90, but it's only just above 90 that we start seeing it. It's not statistically significant based on those confidence intervals, although there's probably statistical heterogeneity. So it's a bit of a wash. Do we switch these people to a DOAC when they're in their mid-80s, or do we stay on warfarin? Well, a wonderful trial was done by Dutch collaborators, the Frail AF collaboration, I think it was about 1,200 patients in the Netherlands, managed with a vitamin K antagonist, generally well controlled. On average, they'd been treated for about 10 years with a vitamin K antagonist. What these investigators did was they randomized them to staying on a vitamin K antagonist or switching to a direct oral anticoagulant. And here you see the lines over time. This is a 1-year study. The bottom line is warfarin or acenocumarole, and the top line is a direct oral anticoagulant. So what does this tell us? It tells us that for those folks who switched to a direct oral anticoagulant, there was a significantly higher risk of bleeding. And the odds ratio or the hazard ratio was about 1.8. So it's almost a doubling of the risk of bleeding. So based on these data, one might conclude that if you're old and you're frail and you're on warfarin, do not switch, because switching will increase the risk of bleeding. Now, as you can imagine, there are many people who are invested in the combined AF dataset. There are many people who did trials of DOACs who don't like to believe this story. And there's a bit of a campaign goes out to say, well, let's prove from the combined AF dataset that in fact this conclusion is incorrect. So I was part of that group of people who did further analyses from the combined AF dataset. Now, before I even show you those data, I want to say I believe these data completely. I think this is a good trial. It was carefully done. It was unbiased, even though it was open label, very unlikely to be significantly biased. The result is clear and compelling. Let me come back to that in a moment. This is what we did in combined AF. We did an analysis of people over the age of 80 who were categorized as frail and who had experience taking a vitamin K antagonist. And we looked at those who were randomized to a direct oral anticoagulant or to warfarin. The green line is warfarin. The blue line is a direct oral anticoagulant. So on the left panel, there was a reduction in stroke or embolism in frail people who get a DOAC. And on the right-hand side, there isn't a reduction in bleeding, but there's certainly no increase in bleeding. And then on the next slide, there was a big reduction in intracranial hemorrhage, and there was a big reduction in the ISTH major bleeding. So based on these data, one would say, well, maybe the Dutch result is an aberration because these were randomized, they're frail, they're old, they're vitamin K experienced. There is no evidence base from combined AF that would suggest that we shouldn't switch them to a DOAC. Now, how can we reconcile these results? My own impression is that the Dutch group, these people were on average on warfarin for 10 years. They were selected out because they'd survived already on average for 10 years on warfarin. And they're quite different people to the vitamin K experienced people in combined AF who may have been on warfarin for as short as 3 to 6 months. So that's a potential explanation. In truth, the data are mixed. So what's the lesson to take home? Frail elderly with AF are at high risk of both stroke and bleeding. Overall, the safety advantages of DOACs appear to be attenuated in frail elderly. That's consistent from frail AF and from combined AF. There is a consistent reduction in the intracranial hemorrhage. My own approach is if a frail older adult is well controlled on warfarin, then don't reflexively switch. And so the questions, I think no change is a good answer. Reducing the target INR is unproven. Switching to a DOAC, I think it's acceptable, but don't do so reflexively. Switching to aspirin, no evidence base to support that. And I don't know what else we might do. We're at the 45-minute mark. I have 2 other brief topics to address, and then I would very much like to hear your questions about anything DOAC warfarin in AF, VTE, or cardiac thromboembolism, or the pharmacology, or whatever you would like, or perhaps related to the cases I've presented. I want to turn from DOACs underperforming to the question of bleeding. And bleeding remains, on the one hand, the single most important barrier to the use of anticoagulants. And on the other hand, it remains one of the least well-studied events in cardiovascular medicine, at least in my opinion. I'd like to ask you a question, and I've already answered the first, that is, which of these are true or false? Bleeding is the single most common adverse event, and I've already told you that that's true, and the questions will pop up shortly. The second question, and I'll put this on the screen, hopefully you can see that. Bleeding is the most common adverse event, that's the first item. The GI tract is the most common site of bleeding, that's the second, true or false. The third, the case fatality of major bleeding is similar to that for MI. In other words, the proportion of people who are dead at 30 days after a bleed is similar to the proportion of people who are dead at 30 days after an MI. And finally, a very important question or statement: most bleeding can be prevented by careful patient selection and targeting modifiable risk factors. So we're seeing a very interesting picture here about bleeding. And please keep voting. I'd love to see lots of you vote on this topic. We're almost up to 30 and we want to get to 35, 40. So most of you agree with my claim that bleeding is the single most common adverse event, which is good. Most of you think that the GI tract is the most common site of bleeding. Maybe I should have said major bleeding, because some of you think about skin bleeding. The case fatality of major bleeding is similar to that of MI. Most of you disagree with that. And most bleeding can be prevented by careful patient selection and targeting modifiable risk factors. About 3/4 of you think where we can avoid most bad bleeding. And I think you've closed the poll. So keep in mind what you voted, and let me jump to my case. Well, firstly, bleeding is the single most common adverse event in patients treated with anticoagulants. That's true. Major bleeding occurs in 2 to 3% of patients per year in the atrial fibrillation trials. This is in a well-controlled, randomized trial setting. 2 to 3% of patients have a major bleed, and clinically relevant bleeding, which includes major and clinically relevant non-major, so they pulled together as clinically relevant, 5 to 15% per year. This is an incredibly common adverse event. It's associated with substantial morbidity and mortality. The case fatality after intracranial hemorrhage is 30 to 45%. And the case fatality after bleeding that's major, that is not intracranial, is 5 to 15%. It's similar to myocardial infarction. Now remember, when we say case fatality, it doesn't imply causation, it just demonstrates association. So my take-home message on bleeding, if there's nothing else I say about bleeding, bleeding is prognostically, major bleeding is prognostically as important as myocardial infarction. So we've got to take it super seriously. And bleeding is potentially preventable. Well, why else do we care about bleeding? It's not just that bleeding has bad outcomes, but fear of bleeding is the most important reason for undertreatment. So bleeding, why don't we treat people? We're worried about bleeding. Physicians prioritize bleeding risk over thromboembolism risk. Patient characteristics. Patients are getting older. Those living alone with severe comorbidities are undertreated. People with a history of bleeding or the use of antiplatelet drugs are undertreated. And then there are other reasons why we undertreat. But for the first three items in this table, they're all related to concerns about bleeding. About 10 years ago, recognizing how bleeding was understudied, how bleeding was often disregarded by clinicians, we embarked on a study called Interbleed. And what we did in this study is we took almost 5,000 people, half of cases with gastrointestinal bleeding and half were controls without gastrointestinal bleeding. And we studied the risk factors for bleeding and the outcomes after bleeding. But we didn't just study the risk factors for bleeding, we calculated the contribution that risk factors made to the population risk of bleeding. So how can I explain what that means? It means that if a risk factor is modifiable, if we take it out of the population, we can remove that proportion of the risk of bleeding. So if we look here at this thing here, on this table, we have the adjusted odds ratio, and let's take medication glucocorticoids. The adjusted odds of bleeding, if you're on a glucocorticoid, is 1.71. The adjusted population attributable fraction is 1.8%. That means that if we eliminated glucocorticoids, of course we can't do that, but if we just selectively took out the contribution of glucocorticoids, we would selectively remove 1.8% of the risk of gastrointestinal bleeding. Now, why are we interested in the average population attributable fraction? Well, I'm going to run you to the bottom line here. Look at the bottom line. Overall, when we add up all of the modifiable risk factors for bleeding, if we were to remove them all from the population, we would remove only about 1/3 of the risk of GI bleeding in this study. So for those of us who think that with careful patient selection, we can avoid bleeding, and by tackling modifiable risk factors, we can avoid bleeding. Well, I want to caution you that most of the risk of bleeding cannot be modified by tackling known modifiable risk factors, because most of the modifiable risk remains unexplained. Yes, age, we can't modify, so sure, we could say, well, don't treat old people, but that's a lot of people we wouldn't treat. So then we'd get into a problem of massive undertreatment. In fact, I'd put the case to you that it's impossible to predict bleeding reliably. Our bleeding risk scores have many limitations. Our bleeding risk scores capture only a small fraction of the modifiable risk factors. And trying to determine who should and should not be treated to avoid bleeding, it's almost impossible. So I'm going to jump to my summary. I'm conscious of the time. What we showed in Interbleed was that potentially modifiable baseline characteristics explain less than half of the population attributable fraction of GI bleeding. And I didn't show you these data, but if we go to the oldest of the old patients, that number of 37% goes even lower. It's in the 20s. Age explains most of the remaining risk, but remember that most old people don't bleed. So selecting people based on age for treatment is not a way in which we can refine our selection of patients for appropriate anticoagulation. So to prevent bleeding today, my take-home message here is All we can do is control blood pressure, avoid dual or triple therapy, maybe use a proton pump inhibitor for high GI bleeding risk. Watch out for alcohol. Remember that fall risk is not an absolute contraindication. And this is particularly important, probably outside of Africa, South Africa, rather than inside, but iron deficiency, as you know, is rampant. Anemia is a very powerful predictor of bleeding, and it would seem very sensible for us to treat iron deficiency aggressively. There's a lot more that could be said about bleeding, but I agree with those who said bleeding is the single most common adverse event. The GI tract is the most common site of bleeding. The case fatality is similar to MI, but I do not think major bleeding can be prevented by careful patient selection and targeting modifiable risk factors. That is desirable, but it's impossible. We need a lot more work on bleeding. As I said, a lot more could be discussed about bleeding, but I want to end on a sobering note about factor 11 inhibition. We've just heard about the importance of bleeding. We've heard that it's a barrier to anticoagulation. The direct oral anticoagulants have had a massive impact on practice. Everybody's looking forward to seeing this new generation of anticoagulant take over the DOACs, be effective, reduce bleeding. But is the promise being delivered, or is it just hype? Well, there are three classes of factor 11 inhibitors being developed. The most prominent, that is, there are three prominent classes. There are other classes, but the most important are monoclonal antibodies. You've heard of abelacimab, perhaps. These are going to be super expensive. They can be given once a month. They're hard to reverse. There are the small molecule factor 11 inhibitors, milvexian, asundexian, given once or twice daily. They're rapid onset, rapid offset. They're going to be convenient. They're not going to be cheap, but they're most like the DOACs that we use. And then there are RNA, strands of RNA that can be used to inhibit the translation of factor 11 protein and thereby lower factor 11 levels. These can be given every 3 to 6 months. They work very slowly to start. The wearing off is very slow. They're likely to be super expensive. That's the common theme. All new drugs are super expensive. But if they were to reduce bleeding, but still be effective for thrombosis prevention, then in the fullness of time, they might be preferred across the board. I'm going to leave my last question here about factor 11 inhibitors. So, true or false, they offer the potential for improved efficacy and safety. Question 2, phase 2 trials have shown promising efficacy signals, and you can put up the questions if you like. Optimal efficacy can only be achieved with 100% inhibition, and the antibodies appear to offer important advantages over the small molecule inhibitors. So, Nicole, do you want to show us that question? And folks, you can vote. This is the last question, if I can find it. I actually don't see it, Nicole.
Yeah, I don't think it's on here. Give me one second.
Okay. Not to worry, but it's probably timely because I need to move on anyway. So I'm going to tell you the answers very shortly, but let's have a quick look at the data from the factor 11 inhibitors, and I'm going to jump a little bit faster. Here is the theoretical basis for testing factor 11 inhibitors. On the left-hand side, we have a situation where there is extravascular injury. For example, someone sustains trauma. When we crush tissue, we produce a lot, or we expose a lot of tissue factor, and we get a very large thrombin burst. That thrombin burst is sufficient for hemostatic plug formation. Then it still needs to be amplified, and it still needs to be, you need to strengthen that clot. But essentially, because of this massive thrombin burst, you're much less dependent on amplification through factor 11 than on the right-hand side of this graph. And here we have an intravascular event, such as a plaque rupture. And when a plaque ruptures, there is only a modest thrombin burst. That modest thrombin burst is not sufficient to form pathological thrombosis. What is required is significant amplification via factor 11 to get a larger thrombin burst, to get an occlusive thrombus that causes the manifestations such as MI or stroke. So you can see from this model that targeting factor 11, if you could block 11, you're going to block the right-hand side of the slide, but you're not going to affect the left-hand side of the slide. You're going to block thrombosis, but you're not going to impair hemostasis, in theory. Now, what have we learned from the trials? Well, I'll show you the one most sobering result of the trial. Here is a result. On the left is ISTH major bleeding. On the right is stroke with systemic embolism. This is a randomized trial of a factor 11 inhibitor, asundexian, compared with apixaban in patients with atrial fibrillation. So you will see that clearly on the left, there is a reduction in bleeding with asundexian. It is going to be safer. But on the right, there is a substantial excess of stroke. It looks like from these preliminary data that the efficacy is not there. Some people have said, well, asundexian dose was incorrect. Some people have said, well, you should use an antibody because you get much more consistent blockade of factor 11. Lots of speculation, no real answers. And at the moment, the research world is waiting on the data from the ongoing randomized trials of other factor 11 inhibitors in AF, as well as randomized trials of factor 11 inhibitors in stroke, in acute coronary syndromes, and in cancer-related thrombosis. Now, I'm going to be a little provocative here and say, if factor 11 inhibitors, if all they do is reduce the bleeding at the cost of more stroke, well, we already have drugs that do that. For example, low-dose edoxaban. This is from the Engage TIMI 48 trial, Engage TIMI 51, I think it is, where low-dose edoxaban in the green line has a big reduction in bleeding compared with warfarin. But on the right-hand side of the slide, it has a higher risk of stroke. We already can get safer drugs, which sometimes we use in people at high risk of bleeding. Is factor 11 inhibition just going to be an expensive replacement for low-dose edoxaban? I don't know the answer. But based on what I've seen so far, that's certainly a possibility. So what to watch for in the next year or so? Efficacy of factor 11 inhibitors versus apixaban or warfarin. That's the big question. How effective are they? If they are effective, what are we going to do when people need to go to surgery, particularly reversal and perioperative protocols with these very long-acting drugs? And can we extend their use beyond atrial fibrillation to patients with devices? So they're the big questions for 2025. So here are the answers to the questions, and I know you haven't had a chance to answer. The only one that I would agree with is that factor 11 inhibitors offer the potential for improved efficacy and safety. The phase 2 trials have shown promising efficacy signals. That's not true. In fact, the phase 2 trials haven't informed us about efficacy, and the phase 3 trials show that it may be less effective. Optimal efficacy can be achieved with 100% inhibition. There's no evidence for that. And finally, antibodies offer important advantages. I'm not sure that we have any data to support that. So in conclusion, I've taken you through 5 different scenarios. We've talked about DOAC failures, we've talked about bleeding, and we've talked about factor 11. This is just a small part of the mosaic of antithrombotic therapy, which remains a super dynamic and fascinating area for research. I would conclude to say that DOACs are the default treatment for most people with VTE-AF. There are some striking exceptions, including rheumatic myelostenosis and extremes of obesity. Breakthrough stroke on a DOAC requires exposure checks and individualized escalation, potentially. In well-controlled, frail VKA users, there's no automatic need to switch. Bleeding is understudied, it's fascinating, but it requires trials in its own right. We do trials on MI, on stroke. Why don't we do trials just on bleeding? We're starting to do them with reversal agents, but we need a lot more work there. And to prevent bleeding, there are various strategies we can employ. Factor 11 inhibition is the next frontier. We will have to see whether they're as effective as we hope they will be. They clearly seem to be safer, but unless they're effective, they're not going to take over this field. And Barry, I'm going to hand back over to you. I've gone over an hour, but I've got time to take any questions.
Great. Thank you very much, John. Thank you for an outstanding expose of a common problem that we face every day. While we're waiting for some questions to pop through, I see there's two things in the chat here. I would like to make like a couple of points. You know, you said that warfarin, the problems with warfarin, one of them where you said where it was a problem was drug interactions. And just to remind you of, and I know that you're working on HIV and TB, but TB is a scourge in South Africa, and almost all our patients have the problems of HIV and TB. And then we have anything that was an ear, any of the drugs that in an ear are strong CYP inhibitors, and rifampicin is a strong CYP inducer. And we have a trial actually, but we've actually, Ton Lensing and I did it because we were the largest contributor to the Einstein study. I don't know if you're aware that we were the largest contributor to the Einstein study, and we did a sub-study called Einstein TB, and we've never actually published it. And I'm trying to get Ton and I to get back and look at it because of the problems associated with that our patients on rivaroxaban or combinations where you don't really know what the outcome is. So, and I think that those patients require regular monitoring. And from a cost point of view, where to go out. And then the other problems also is where the drugs are not available in this country, and they're still not available in a lot of our rural areas. And the other problem that we also face is we don't do TTRs. Most of our labs only give us an FRR because of the complexity in doing TTRs. And a lot of people don't have access to go on a regular basis to go and have their blood tested. I had an interesting discussion with a professor of cardiac surgery from Kenya, where he says the commonest cause of death there from replacing, and we didn't discuss here artificial valves, the commonest cause of death is actually bleeding from their patients get from warfarin.
Wow.
But another problem that we have in this country is different warfarin. So we have different generics, and they have different potencies, and you need to know that when your patient swaps from warfarin A. The two major players in this country are aspirin and Cipla, but you have to know which warfarin your patient is taking, and if they swap at the pharmacy, then their INR can go out of control as well. So just a few of my my thing, but I agree with you that, for example, in the elderly patients, that my feeling has always been if it's not broken, don't fix it. So if they're doing well, why do you want to change it? But I do think that the data is out there for low dose apixaban, and I think your point taken, and it's a very valuable point. It's quite hard to get across to our audiences in South Africa is to test, even to test occasionally to check that your patient is taking their medication and that the drug is actually working. Because living in the third world, it's not the first time that we've had medication dumped on us that doesn't work. So it was an excellent expose. And I'd like to go over to the questions. I don't see questions. Any questions out there? I'm sure there's a lot of questions for you, John.
Barry, that was your little summary there was absolutely fascinating. I hope you're going to publish the Einstein TB data because that's incredibly.
Yeah, I know that unfortunately Poor Ton Lensing's had some personal issues, so we're waiting for him to recover from them, and then we are definitely going to publish it because it is fascinating, fascinating data. We also I had an M.Med that never got actually published because he went into private practice, which I'm very cross about. But he showed that the incidence of DVTs in TB occurred in the first week, that there was a marked peak of DVTs, and probably from the initiation of the rivaroxaban of using the TB medication, specifically rifampicin, seems to be the major culprit behind that. But we do know that that there's a high incident initially. And the other problem that, well, with warfarin in this country, with HIV, that we wrote guidelines, and I'm in the process of rewriting the guidelines, and we hope to have them out shortly, was that you will see in our guidelines, we state that warfarin should only be started on day 2, as opposed to all other guidelines that start on day 1. And the reason we did that was a logistic reason, because in South Africa, enoxaparin is often not available, and the patients, warfarin is freely available, and the patients get their warfarin prior to, or they don't get their enoxaparin. And in South Africa, that's particularly dangerous because of the prevalence of HIV. And there's a very nice paper from the people outside Somerset who showed a huge number of patients getting acute warfarin-induced skin necrosis, especially because the HIV patients have got a low protein S, and a lot of them have got antiphospholipid. So there is that prevalence in South Africa. Using warfarin ab initio is not a bad, as long as the patient gets covered with enoxaparin prior, because of their low protein S associated with the underlying HIV, which doesn't really occur in other countries. Any other questions?
Really
Maybe
important
we
points.
can.
Would have
Sorry?
been nice to have a slide which, this reflects, inside information. I mean, it would have been nice for me to been able to present a couple of slides contrasting those key points. I mean, I've made notes, but Einstein TB and HIV, that's huge. I mean, the availability, the TTR question, which you can actually calculate TTR with a little Excel spreadsheet on your own computer. You just need to, it's just a little formula to calculate. It's pretty simple, but it's incredibly powerful. And then the different potencies of vitamin K antagonists. I guess you've probably written little reviews for your South African Medical Journal on this topic, but all very important points.
Oh, I'll send you my guide. Maybe you can give us some inputs when we've got the guidelines, and you can have a look at them and make some suggestions to us before we publish them.
There was one question about
discuss-
triple positive antiphospholipid.
Yes, the triple positive antiphospholipid. So I want to hear your views, because I've got quite strong views.
Yeah, me too, and we probably align fairly closely. So if we look at the randomized trial data, they're incredibly sparse. And Mark Crowther wrote the editorial from a meta-analysis in JACC about 3 or 4 years ago. And the evidence that warfarin should be preferred over DOACs is primarily driven by triple positive antiphospholipid antibody syndrome. And it's much less convincing, in my opinion, for a double positive or a single positive. What's more, single positive antiphospholipid antibodies, I mean, we see them all the time, hospitalized patients. It's very common. It depends a little on whether you've got a sensitive reagent, a reagent sensitive to lupus anticoagulant. So I would suggest, particularly when warfarin is hard to manage, that unless you're triple positive, it's reasonable to use a DOAC. And
I agree with you entirely, and I think that, I mean, I know that Harry Bueller, who's a friend of mine, is now retired. He was also at McMaster's at some point in his life.
yes,
You trained there with you guys. And I mean, I disagree with him quite strongly on that, because if you look at those trials, I mean, the 2 randomized trials, they excluded all the patients who had difficulty controlled with warfarin. So what had happened to those patients? I mean, that's the issue. So I understand that primarily you'd like to go into warfarin, but the majority of those patients, and then also there's the difficulty with the reagents, measuring the INR in these patients. So they often have difficulty, and you can't use Innovin on these patients. And a lot of the labs don't know that. And I'm anti, and I'm measured, and I've got quite a lot of patients now, triple positive, who won't go, refuse to go and have their warfarin tested every week and bounce all over the place. And I've got them on, and touch wood so far, they've done very well. And I'm hoping to get enough of them to write it up, and then to show that I don't agree that even in triple positive, the problem that we have is once this data came out, is that the funders refuse to pay for the NOACs. They say no, the data is not there for the triple positive, and therefore they're not prepared to fund it, and the patients then are forced to self-fund it, which I don't necessarily agree with. So I think that the triple positive, and if you look, I mean, those trials, they all excluded those
Yeah.
patients. We took patients who were well controlled on warfarin. Hello, the
Yeah.
majority of my patients who are lupus are not
Not-
well controlled on warfarin.
Yeah.
So
Yeah.
what are you going to do
Exactly.
about those? I mean, they don't discuss that, and that's a big issue for me.
Yeah. I think that the guidelines, more than ever before, seem to be have their heads in spaces that are disconnected from patients. So
Yeah,
there's arbitrary rules about guidelines and how you interpret evidence, but they don't realize that at the bedside, the situation can be quite different. So especially antiphospholipid syndrome, we're actually trying to write a paper on this topic. It's not really that complicated, but we figured there was an urgent need to sort of reset people's thinking that high
and
quality evidence is restricted to triple
yeah,
positive.
and the definition of the antiphospholipid syndrome comes out every year from the expert committee from the ISTH, who are all self-appointed experts. I
Yeah.
don't, and it's all gobsat, good old boys sitting around the table. So I remain under, it's a difficult disease that I don't begin to understand, seems to wax and wane over time, and can be devastating and horrific, and in other patients can do absolutely nothing. So I don't begin to understand it. I've been dealing with it for years, so I don't understand how they get to make these decisions. And it's so I'm curious about. I mean, I tell my patients, I say to them, look, the guidelines, for what they're worth, say to you that the first line, the optimum therapy for you is warfarin therapy. I'm happy to try it, and we can do it. And if your INR is well controlled, a lot of the patients say, doctor, I can't go every week or then every month to have my INR, it's well controlled. And, and, uh, and they then opt out because financially it's not viable for them to take off and to go and do all these
Yeah.
tests.
Yeah, for sure.
Pit vessels are not starting harder. So I'm not quite sure, Pit, what you mean by not high doses of warfarin. I'm not quite sure. Pit put in his comment here. Pit is an old friend of mine. What do you mean by not starting high doses of warfarin? Please either talk to us or
No, Barry, what I mean is they start with a 10 milligram instead of a 5. It's a
okay,
crazy.
thank you. There's no data on that. Yeah. Good. Thanks, Pete.
We've largely abandoned it. We don't use, there used to be a 10-10-10 or a 10-10-5, which we don't
And the
use.
idea of doing the the genetic profiling and decided which patients are going to be mildly warfarin resistant, I think personally is not cost effective, and I'd never do it.
There is a new or a rediscovering an old finding. We know that INR results or the effect of warfarin on thrombin generation is well reflected by the effects of warfarin on factor 2 and 10, but not so much on factors 7 and 9. And
Yes.
so there is a group from Iceland that have promoted the use of the fixed INR based on factor 2 and factor 10, and using repleting these INRs with the assays with 7 and 9 and just focusing on 2 and 10. And they suggest that you get better INR control with better outcomes, and you're not affected by the wild fluctuations of 7 and 9, which doesn't matter too much. I don't know your thoughts about that, Barry.
No, I don't have any really strong thoughts. I don't know much about it. So I mean, I know they've been doing it, but I'm not really au fait with doing it. It might be an interesting way to look at it.
Well, we have
Any
a
other
clinic
questions?
with 600 mechanical valves, and about 15% of them run time and therapeutic range of less than 40%. So we're a bit desperate about these folks, and we wonder whether it's spurious and whether, because their event rates are still fairly low, and so we think we're going to test the new fixed INR method.
It'll be nice to know. I'd really be curious to find that. Whether they'll be able to implement it into a rural area, I don't know. I mean, there's this desperate need, and I'm going to relook at it to do a trial in Kenya on the heart valves because their death rate is so high from bleeding. So, I mean, many years ago, I went to give a talk in Mozambique on anticoagulation and discovered that they weren't measuring any INRs. And so my good friend Martin Sussman, who at that time was working at Charlotte Hospital in the public sector, he was doing all the heart valves, mitral heart valves for all these rheumatic heart disease and sending them back to Mozambique. And I said, you're costing R1 million, sending them back to somewhere they don't even know how to control their INR. So, what are we doing? So I think that in the third world, there's a very good need if we can. I know the trials unfortunately didn't pan out, but they didn't measure levels. And if we can get a better trial going where we can measure levels and look for heart valves, it might be a major breakthrough for the third world, where we could offer these patients better care in the third world. Because the warfarin control in rural areas is abysmal. We still have 112 people. Are there no questions out there? Obviously, everything was crystal clear for them, which is amazing because the more I learn about coagulation, the more I realize I know nothing.
Well, a common feeling, but no, I'm very grateful for the opportunity to interact with colleagues in South Africa again. And it reminds me that, in Canada here, I only understand a small part of what you face in a different environment. And your closing comments, your earlier comments are resonating with me very powerfully, that there are unique circumstances in your case that need attention.
Well, thank you.
Good afternoon, Barry, and hello, John. It's from Estelle.
Well, hi.
John, once you come back and you actually make it clearer to us, we will start asking questions. It's far too complicated. No, it's not.
Oh, I'm so sorry.
No. It's brilliant. I think I just think we must think about these things more often. And you gave very, very practical cases. And I know that the trainees love, love, love cases and real world scenarios. So thank you, thank you so much, John. And thanks, Barry. It was great. Next time we'll ask more questions. I'll
I
study
have
them
a
beforehand.
question for your next speaker. I think Barry should speak on contrasting or on unique aspects of anticoagulation management in South Africa.
That sounds great. What do you say, Barry?
Not at the moment. I'll have to wait a while. I've got 3 other talks that I have to give and guidelines
Yes,
to write. So
and
I'm
you've
a
got
bit
a
under the
conference
cosh.
coming up.
Yes, we've got a
What's the
conference.
date of the conference?
It's the 2nd of November. I put it on the group.
Okay. Yes.
Thrombosis
Okay.
and hemostasis. So please, please please come, and we've got a discounted rate at the Houghton Hotel, and maybe there'll be opportunity to come, John, and take a flight out to South Africa.
Well, maybe, but if you invite me next year, I'll definitely come. It's a bit hard for
Definitely.
November.
Yeah.
So
Thank
we
you,
look forward to
everybody.
that.
Well, thank you
Thanks,
thank you, everybody, and John, thanks once again for giving up 2 hours of your morning. What's the time there now?
It's 11:30, so off to the
Oh.
ward.
Okay, a full day to go still. Thank you, everybody, and we'll see
Bye-bye.
you all again next week. Thank you.
Bye,
Thank you so
everybody.
much. Bye.
Bye.